Hello, welcome to the TBI Matters webcast presentation. You are in the right place. We are just a little early. The presentation would start at 6 p.m. sharp. Again, welcome. Remember to turn off your mic and turn off your webcam. And I think some of you that I see logged in have already done so. So thank you again. Again, you're in the right place. We're just going to be starting around 6 o'clock sharp. Thank you. It's not working. There you go. Is that it? I'm turning the mic off right now, but again, you're in the right place. Thank you. We're setting up. Test, test. Yes, I have the sound off. It will be coming back on once the presentation gets started. Again, we're going to be starting at 6 p.m. Again, welcome to the TBI Matters webcast. We're going to be starting at 6 p.m. sharp. Thank you for your patience. Bye. So right now you're live. Okay. Yeah,
for hyperbaric medicine. It's in downtown San Francisco. And I also consult for a company in New York called Hyperbaric Medical Solutions. Today we're going to talk about hyperbaric oxygen therapy and traumatic brain injury. And it's a big topic. There's a lot of information. Some of it's technical. And I'm going to try to make it as easy to understand as possible. I may not be always very successful at that, though. I know that ahead of time. So if you have questions, please, you can stop me. If it's a burning question, I'm happy to stop. If you feel like maybe you could wait until we'll have a very long question and answer session afterwards, then you can answer it. You can ask it then as well. So without further ado, we're going to get started. All right. Actually, last thing before I get started, it sounds like most of the audience here today knows somebody affected with brain injury. Is that correct? Okay. Do we have any professionals in the audience? Any occupational therapists? physical therapists. Okay. Any doctors? Okay. Well, there you go. All right. Okay, great. So that gives me a little bit of an idea. So some of my slides, what I want you to guys, if you look at them and you're like, wow, what does that mean? It's okay. We'll explain it as we go. All right, I promise. So I want to start off with, well, this is a basic overview of what we're going to be talking about today. I'm talking about some basics about what hyperbaric oxygen therapy is, what the mechanisms of action are, some of the FDA approved indications for hyperbaric. And what I mean by that is that any insurance company will cover them. We'll also be talking the bulk of our talk on hyperbaric oxygen therapy and traumatic brain injury. And I'm going to talk about not only the positive things that have been coming out in the news, but also some of the negative things, and sort of trying to explain all that and trying to make it more understandable and sort of boil it down and give some more information on it. We'll talk about hyperbaric side effects and contraindications, cost, as well as locations. So first question for the audience, does anybody know where this is? There you go, it's New York. Now what bridge is that? Very good, very good. Didn't take any time at all. I thought, so this is where I'm from New York. But the reason I put this picture up was not because I'm from New York, maybe partly, but these areas right here were built. Does anybody know when it was built? So 1870, that was good, whoever said that, 1870. So when it was built before we knew about decompression illness or the bends, okay? That's where hyperbaric oxygen really started as a treatment for the bends. These guys were underwater building this bridge, those big pylons. They were called caisson workers. And they were working all down on here. The water level was up here, okay? These guys were in these big chambers digging out the muck on the ground. If they came up too quickly, a lot of people died, and they didn't know why. And this is really the birth of hyperbaric oxygen medicine, when they realized that something was happening to these patients, or these workers, when they were coming up to the surface after being deep down under the water. Okay. All right. Okay, so I want to start off with a definition. What is hyperbaric oxygen medicine? Hyperbaric oxygen is the intermittent administration of 100% oxygen at higher than atmospheric pressure, okay? Atmospheric pressure means sea level, okay? We're basically right now, all of us, at sea level, all right? This scuba diver right here, I guess I don't have a clicker, do I? At this point. This scuba diver right here is at sea level, okay? We define sea level as 1 atmospheric pressure, 1 ATA, okay? This is just going to become important when we're talking about some stuff as we go down through the talk. 2 atmospheres of pressure is 33 feet of seawater. And the reason why we're using divers here is because hyperbaric oxygen medicine really came about, as I said, because of diving medicine. And then at 3 atmospheres of pressure, 3 ATA, you're 66 feet under the sea, okay? Now, when we're swimming in the water, any of us, all that water above us is exerting a pressure on us. We don't feel that pressure because we're just kind of swimming and hanging out, okay? But it is exerting a pressure. If you carry a bucket of water, you know how heavy that is, right? All that water is exerting a pressure on your lungs. That's part of what's happening with hyperbaric oxygen therapy. Now, all of us, for the most part, if we don't have underlying lung disease, are already saturated with oxygen in our body. We have to be. That's how we live. We need oxygen, right? If you look at our red blood cells, which are the cells in our body that actually carry oxygen, okay, 97% of the places that they can carry oxygen are already taken up when they go through the lungs, okay? So then the question is, well, what is hyperbaric oxygen therapy doing if there's only 3% left to really saturate, if at all? You might put something, this is called a pulse ox machine. I don't know if anybody's seen one before. You put one on the finger. Typically, if your normal lungs, it's 97 to 100% saturated, okay? So what hyperbaric oxygen therapy is doing is increasing oxygen delivery not only into the red blood cells, into these sites on the red blood cells, but actually into the plasma of our blood, okay? Now, the plasma of our blood is basically like the water of our blood, okay? when somebody draws blood from your arm, what's going to happen is that it's going to look like this. It's going to look like a test tube of red blood. But it's not just red blood cells. In fact, it's made up of lots of different particles, okay? Red blood cells, white blood cells, and this, it's not really projecting very well, but this is basically just plasma or water, okay? When we're just breathing right now at sea level, this has very little oxygen in it, okay? This is what we can do with hyperbaric therapy. We can increase this substantially, more than you can do with just breathing air. And the reason for that is the pressure, okay? And this is a physics law. It's called Henry's law, okay? Hyperbaric medicine is very, very much based in physics. But it's an easy concept, okay? The more pressure you put on a gas, in this case, imagine these are oxygen particles right here. The more pressure you put on them, the more goes into liquid form, okay? Does that make sense? It's just the nature of physics, okay? The more pressure on a gas we put, the more is going to be put into a liquid state. So that's what we're doing. We're super saturating the blood with oxygen. More so than you can do just at sea level with even a face mask of oxygen on it. So this is a complicated slide, and don't worry about it too much. What I really wanted just to mention is that at 3 ATA, or 3 atmospheres of pressure, okay, that's about 66 feet of seawater. If you're in a hyperbaric oxygen chamber that's simulating this pressure, you don't need red blood cells, okay? You can saturate the blood with enough oxygen that you don't need any red blood cells at all. All you need is the blood plasma, and you do just fine. Now, of course, when you left the chamber, that'd be a problem. But in the chamber, you'd be fine. That's just to kind of give you an example of how much oxygen we can saturate into the blood. Okay, so what do the chambers look like? This is my facility in San Francisco. These are called Monoplace Chambers, single-person chambers. So one person goes in at a time, for the most part. And people lie flat. They can be, you can be, sort of, propped up too. We actually have another chamber now that's even bigger than these. These are for one person at a time, and they have televisions that you can watch while you're getting therapy. It's very relaxed. These are called multiplace chambers. This is a multiplace chamber here. These are usually seen in hospital settings, typically in trauma centers, where there's lots of patients that need to be treated all at the same time. Okay, that's what you're seeing here. All these guys and girls are being treated all at the same time. I don't know if you can really see in the picture, but they have these sort of masks or hoods on their heads, and this is actually what's pumping the 100% oxygen into the multiplace chamber. Burn victims, carbon monoxide poisoning, I said burns already, and infections that are very severe that require hospitalization. That's where we see these multiplace chambers used most. So what does it feel like to be in a hyperbaric oxygen chamber? Okay, I try to make this very simple. Okay, you start at sea level over here. Okay, and as you saw in those chambers, you're just kind of sitting and relaxing. The simulated pressure brings you down to 1.5 atmospheres of pressure here. While that's happening, it's like you're going under the water, except you don't feel like you're underwater. It's the same pressurization, okay? So the only thing that you're feeling is that you're feeling like if you've ever been on an airplane or on a train, you feel that pressure sensation in your ears. That's what you feel. If you've ever been a diver, if you ever dove down deep, it's the same thing you need to be able to do. You need to pressurize your ears while you're going. When you get to the level that we're treating you at here, you don't have to pressurize anymore. You just relax like you're breathing like you are now. And then at the end, you come back up. And it's the same process. As you go up, you have to make sure you clear your ears as you go. Yes, that's minutes, yes. So this is 10 minutes, 60 minutes, and 10 minutes here. So yeah, thank you for pointing that out. And I also wanted to mention, so the experience also depends on how oxygen is being given to you, okay? You can either get oxygen ambiently, so you're just breathing it as we're breathing now, and it's just being piped in around you. Or, like you saw in that multiplace chamber, it could be coming in a hood or a face mask, okay? It just, yes? So it takes time. It takes time to go from sea level to where you're starting to go to the treatment depth that we want you to get to. For everybody, it takes a different amount of time. For the most part, after a couple sessions, you get used to how it feels and get used to the feeling in your ears especially, and you learn how to clear your ears very quickly, and it can happen, you can get down much quicker than that. Oh, right. So the question was, thank you, forgot about that. The question was, how long does it take to get to the pressure that we're treating you? And the answer, as I mentioned, it just depends on how you do. But for the most part, it's around 10 minutes or so. For the people that are master divers, it can take 2, you know. And we have divers that come in and have no problem. So I'm going to focus now on what hyperbaric oxygen therapy does. What is the mechanism of action, okay? And I think this is probably the most important part of the talk, because as you will figure out as I'm going through this, the mechanism of action is universal to wound healing, okay? It's universal. Every wound needs to heal the same way. Hyperbaric oxygen therapy heals wounds. It heals them faster, sometimes more efficiently, and its mechanism of action has to do with DNA in our cells. Okay, what it does is it upregulates and downregulates gene expression. So what that means is that on our DNA we have code, right? We have our genetic code. Those genetic codes give us proteins. Okay, hyperbaric oxygen therapy has been shown to affect about 100 different genes so far. Some of those genes it upregulates, meaning it increases the production of their proteins. Okay, proteins that are related to growth and repair and decreasing inflammation. It also downregulates or decreases the production of genes that are responsible for cell death and for inflammation as well. Hyperbaric oxygen therapy also works directly through actual oxygen delivery as well. And I'll explain that a little bit more as we go. So how does it work? The downstream process of increasing gene expression or increasing some proteins and decreasing others is decreasing inflammation. So I'm not sure if you know what dexamethasone is, but it's a steroid, okay? Steroids are one of the most powerful anti-inflammatories that we have. Hyperbaric oxygen therapy has been shown to be as effective as dexamethasone at decreasing inflammation. So pretty significant, okay? Another thing it does that's very important in injury is that when you have an injury, you usually have swelling, okay? The swelling happens usually because you have vessel injury. You injure vessels, the vessels lose all that plasma, lose all its components, all that goes into your tissue. What hyperbaric oxygen therapy can do is decrease the size of those vessels, called vasoconstriction. When it does that, it's preventing all that swelling from happening. It decreases the amount that can get out. Now, the question that arises, well, if you're decreasing the size of the vessel, aren't you decreasing oxygen delivery, right? Because you're decreasing the amount of blood flow if you're squeezing these vessels. The answer is that that's not the case with hyperbaric oxygen therapy because you're supersaturating that plasma, okay? And I'm going to show you a nice little picture about that in a second. So it amplifies oxygen gradients. So I don't know if you remember back to what osmosis is, but things tend to go from from high concentration to low concentration, right? So the more oxygen you have diffused in your blood, the more that can be diffused out of your blood into tissue, okay? And increasing those oxygen gradients is what stimulates all these cells that are not, you can't see the slide there, but it's Mac versus PC, what can I do? But anyway, so it stimulates all these cells in our body that, that increase wound healing. Fibroblast cells, which are the connective tissue cells that make our wounds heal. Collagen, which is what's missing there, which is the cushion of our joints, and osteoblasts, which are cells in our bone that rebuild bone. So increasing that oxygen gradient, along with the gene expression that I talked about, that's all going to amplify wound healing. A couple more mechanisms of action. Angiogenesis. So what that means is increasing vascular formation, increasing vessels forming, okay? Blood vessels we're talking about, okay? It stops cells from dying. And this has actually been shown to happen. Apoptosis is a very long, sort of a complicated word sounding. What it really means is that what our cells do when they're scared sometimes is they automatically kill themselves. They program-mediated death. And the reason for that is to prevent them from going awry, from causing cancer, a number of different things. But what hyperbaric oxygen therapy is able to do is prevent those cells from dying, okay? And what it can do to rebuild those cells is improve some of the mechanisms that the cell uses to make energy, okay? And that really comes down to something called the mitochondria. I know these are a lot of big words, okay? But the mitochondria is the engine of our cell, okay? It really makes energy. It takes this oxygen that we're giving these cells and makes ATP. ATP is the source of energy for these cells. So what hyperbaric oxygen is doing is regenerating these cells. It's energizing them and making them function optimally, okay? Oh, and then also stem cells. Does everybody know what a stem cell is? Okay. How I think of a stem cell is it's basically like a blank canvas cell. It can do anything in the body that it wants to do. All it has to do is be told to do it. And what hyperbaric oxygen therapy seems to do is mobilize these cells to the area of injury. It also stimulates them as well to increase production from the bone marrow, at least, and probably from fat tissue as well. So this is an artist's depiction of what hyperbaric therapy is doing here, okay? You have a narrowing in your vessel, whether it's from an injury, most likely some sort of injury, you know, whether it be a TBI or it might be a cut on your leg, or it could be anywhere. It could be in the, it could be an organ in your abdomen. But what's going to happen a lot of times is that you don't completely sever that vessel, right? You just make it so maybe red blood cells can't pass through. But so when red blood cells can't pass through, you may still be able to get plasma to get through, okay? But when you're not in a hyperbaric oxygen environment, all this tissue not getting oxygen is releasing all these inflammatory factors that's causing this tissue to die, okay? However, in a hyperbaric oxygen environment, oxygen can still get through because you're supersaturating that plasma with oxygen, okay? That is the key. And I'll try to reiterate that over and over again. It's the supersaturating, the hypersaturating of the plasma that's really doing the bulk of the work. And because we're able to do that in this example, oxygen's getting to all this tissue, so it's not dying. And it's also stimulating more blood vessels to flow around that blockage. It's a simplified depiction, but I think a good one. Okay, so any questions before I move to some indications for hyperbaric? That's right, yes. There are some rewards to that. So how do they separate from the good cell research and not making disease run rampant? That's a really, really good question, and thank you for asking. Really, I appreciate it. So the question was, I mentioned that hyperbaric oxygen therapy is preventing cells from dying, okay? Apoptosis or cell-mediated death. The question, and a very good corollary, and something that should be mentioned is, well, if that's the case, does hyperbaric oxygen therapy stimulate cancer cells as well? Should we be worried about hyperbaric oxygen therapy in the setting of either promoting cancer or starting cancer? And the answer is overwhelmingly no, okay? When I'm talking about programmed cell death, what I'm talking about in that particular instance is in the acute phase of an injury, okay? In the acute phase of a trauma, okay? There have been a number of reviews on whether hyperbaric oxygen therapy stimulates cancer, and the answer is overwhelmingly no, okay? They looked at several different types of cancer. They looked at anything from colon to bladder to lung to brain. There's no indication that hyperbaric oxygen therapy makes cancer grow quicker, nor does it make cancer happen, okay? And the reasons for that are a little bit complicated, truthfully. But the basic idea is that cancer cells in general are hypoxic cells. They have a lack of blood flow to them. So in general, they don't like oxygen environment, okay? So we're not stimulating them to grow. If anything, we're preventing them from growing quicker. Now, I'm not saying that hyperbaric oxygen therapy can cure cancer. I'm not saying that. But what I'm saying is that there's some interesting stuff going on in research about hyperbaric oxygen therapy as being part of, part of a solution for cancer treatment, okay? And the reason for that is because some of these cancer cells actually have what's called a hypoxic core, or the actual area where they're growing actually has a lack of oxygen. So one of the ways it's being used is in sensitizing tumors to cancer drugs, to chemotherapy and to radiation. Actually, if you flood that area with oxygen, more chemotherapeutic drugs can get to that cell, and more radiation can get to it as well. So there's some experimental protocols that are happening right now using that sort of stuff. Does that answer your question? Okay. Okay. Any more questions? Yes. That's a really good question too, and I'm going to ask you if you wouldn't mind holding on to that question until after I'm done. The question was whether hyperbaric oxygen therapy is effective immediately, or when's the best time for hyperbaric oxygen therapy? That's really the question, right? And I'm going to get to that a little bit at the end after I talk about a little bit what's been done so far in hyperbaric. Any more questions? Okay, so what are the approved indications for hyperbaric oxygen therapy? This is a long list. Some of them are big words, as I said. The most common thing that we treat, the two most common things, when I mean approved, is that insurance is going to cover the condition, okay? Radiation tissue damage, okay? So radiation, most commonly used for cancer treatment, okay? Radiation is also pretty caustic stuff. In general, radiation has gotten a whole lot better in the last many years, but there's still a very high, a very low probability. About 10% of patients really have complications from radiation injury. We see a lot of these patients. We do a lot of great things with them. In fact, hyperbaric oxygen therapy is really the only potentially curative therapy for radiation injury. We're talking about patients with brain cancer that get radiation, with head and neck cancers, prostate cancers, bladder cancers, and symptoms that they have as a residual from radiation injury. And we can talk about that more in the Q&A if there's any specific questions about any type of cancer or radiation that you might have a question about. Okay, and diabetic foot ulcers, that's also the most, probably the second most common reason why we treat patients in our chambers. Diabetics that have had non-healing wounds for over 30 days, we have a lot of success treating them, a lot of success. Okay, so this is the meat of our discussion today, hyperbaric oxygen and traumatic brain injury. But I wanted to get there after talking about the mechanisms first, to really make sure you guys at least had a basic idea, you know, of what's going on. Because again, the key is the mechanisms of action, okay? Because that's what makes, what I think, and a lot of people in my community think, is the key to hyperbaric oxygen therapy success, okay, is the mechanism. And why can it be applied to a lot of different types of injury? Okay, so I wanted to start with a couple cases, okay? This is a case from my office. This is a lady that actually is being treated now. Former high-functioning executive, vice president of a major company in San Francisco. She fell and hit her head very, very hard on a door frame. In fact, she doesn't remember. She woke up in bed 15 minutes, 20 minutes later. She's not sure, okay? After the event, she couldn't walk. She fell a number of times. She brought herself to the emergency room. Her husband brought her. Workup in the emergency room was normal, okay? Normal CAT scan, normal blood studies, everything was okay. They told her to go home, to rest, okay? This is really common. Concussions are so common, and we're going to talk about how common they are. But she didn't get better. In fact, she got worse, okay? Difficulty with short-term memory, concentration, attention, executive function, migraine headache. So executive function, what that means, it's part of this frontal part of our brain, okay? That's responsible for planning, for remembering things in the short term, for getting places, for, you know, for basically being able to follow directions, things like that, okay? So impulsivity followed, okay, with secondary depression from all the symptoms that she was having. This may sound very familiar to a lot of people, okay? She tried to commit suicide twice in the same month. Thankfully, she wasn't successful. But as we all know, suicide is very, very common in the TBI community. I think a veteran an hour is dying at this point from the wars in Iraq and Afghanistan, from TBI and PTSD and other sort of injuries related to their service. So she stayed in an inpatient psych unit for 35 days. So she's actually finished her 68th session. She's been getting the hyperbaric oxygen therapy protocol for TBI, which is 1.5 atmospheres of pressure for 60 minutes. She's had significant improvements. And she's not back to normal, but she doesn't have headaches anymore. She can find she doesn't have any problem finding where she's going anymore. She doesn't have any issues with her memory. Her short-term memory is back. Okay. Some of the depression aspect is still there, but she's doing significantly better. She really does feel like she has her life back. And I can't stress to you enough, this is not an uncommon scenario for what I do. We see this all the time. Yes. Right, that's a good question. So impact testing is a neurocognitive test, okay? It's a test, so the question was, what is impact testing? So impact testing is a neurocognitive test that tests for traumatic brain injury symptoms, okay? It's a computerized test, lasts about 20 minutes. You can do it in our office, that's what we typically do. We test somebody before they start, we test somebody at 20 treatments, we test somebody at 40. I can tell you that in my experience, I've never had a patient not improve, okay, that had a TBI. So that's what we use in our office. There's other testing as well, but this is a very easy test to use, and it's a very well-studied test for traumatic brain injury. Okay, so the question, the question is, do we do testing a year later, neurocognitive testing on these patients? And the answer is not typical. We get a lot of patients that say, well, we always try to follow up with patients. We always try to follow up how patients are doing. And what I can tell you straight off is that no TBI patient is ever completely back to having a normal breath, okay? But our experience is that these patients continue to do well, okay? I'll talk about this a little bit later, but I can bring it up now. There probably is a role for maintenance hyperbaric therapy, okay? Now, there's no studies on this yet, okay? So I can't say this is absolutely what we need to do. But the thought is that patients, in our experience, improve dramatically. But occasionally, if they have another injury or if they have another severely stressful event, they may have some reappearance of some of those symptoms. We've treated patients sort of empirically with more therapy, maybe 5 treatments, and they've done significantly well just with a little bit of therapy. Now, this is just anecdotal, okay? In general, our experience is that patients significantly improve and remain significantly improved. Although to answer your question specifically, it's not our policy, we don't do a lot of impact testing in Europe. That's something that I think we should do. And I think it'd be great to put that into some study development. In fact, we're doing a little bit of that with a couple of the studies that were just recently published, 6-month data. So, yeah, good question. Sure. So the question, and somebody asked a similar question, and if it's really pressing, I think I should answer it now. The question of whether getting treated sooner is more effective than getting treated later. In this gentleman's example, he had a TBI about 40 years ago. Is that right? So 40 years ago. So the answer is that most likely, and this is kind of being drawn out in the studies as well, the more recent the TBI, the more success, the more improvement that you're going to have. That's not to say that you won't have improvement. It's been a long time ago. In fact, we've treated patients with TBIs many years ago with success. You can't tell what's going to happen for any individual patient. But overall, the longer that the injury has been there, the harder it is to treat. Now, you see 68 sessions here. And I'll talk more later about what the protocol is for hyperbaric therapy for TBI. But in general, it's a 40-session therapy. Okay, but for patients that have had TBIs a long time ago, there definitely seems to be a role for further therapy, up to as many as maybe 120 treatments of therapy in some cases. 80 is usually as far as we go for the most. Does that answer the question? Okay. Okay, so this is going to be a video. If I can, this guy's name is Jesse Ruiz. He's a veteran coming back from the wars in Iraq and Afghanistan. Is it going to work? There may be a commercial before it starts. I don't have any affiliation with it. Just tell me one. Ready?
Soldier says he is proof that an experimental treatment for your injury does who was among the dozen soldiers who retired at the Hyperbaric Chamber to see so-called invisible wounds of war. Who are unable to put a family where the formula coming from soldier who has in the poor in the Iraq specialist Jeffrey Reed survived this study on paper record 46 ID impacted on my vehicle. They were around 50 meters.
Concussions that led to seizures that led to confusion.
They just basically looked at me like a broken toy.
A suicidal toy diagnosed with severe post-traumatic stress.
It just became
MTBI.
a very downward spiral.
The Army sent him home with prescriptions for a half dozen antidepressants.
It was hard, and then I got angry because I gave the Army a healthy style, and then I got a broken style, and he came back.
I had started to become a little, like, more and more distant every day, and it was a unique experience.
Until he found Ray Crowley, a physical therapist in Florida who needed soldier guinea pigs willing to take a chance on a simple idea.
So we embarked on treating soldiers for free because I was convinced that I could help them.
We put them in a hyperbaric chamber, pressurized oxygen that speeds healing for burn victims and divers with a bend. Crowley believed it could help brain injured and psychologically injured veterans too.
Most of my soldiers, some of them have been out for years, but they have a huge change with this simple technique.
And the idea was, I thought it was cockamamie, I guess.
But after 40 treatments, Reed and his mom don't think it's cockamamie anymore.
She came to me and she started already to cry. She gave me a hug and she's like, "You're present. That's the word. You're here now." And we both shared a good cry. And at that point, it worked.
Ruiz is now down to one medication. He's back in school. He's on the dean's list.
He's back. And that's what it took out, but he's away.
And now the Pentagon is conducting its own studies to see if, like Jeff Ruiz and his mom, can become a convinced believer too. Kevin Reese, KHOU, 11 News.
Incredible story. We thank Specialist Ruiz for his service.
Okay, so it's a pretty impressive story, right? We see this all the time. He referred to two Department of Defense studies that have recently been published, and we're going to talk a little bit about those and the controversy surrounding them. You have a question? Yeah. I think that's what this lady was asking before. The question was, is it a lasting effect or is it temporary? And the idea is once we regenerate cells, once we regenerate these cells that are not working well, and I'll talk in just a minute about how that works. We find that these patients continue to do well. Okay. As I mentioned, there may be some bumps on the road. I'm not saying that somebody with a TBI ever has a normal brain again, but they can get significantly better. And as you can see, come off significant amounts of medication, have a normal life, and we do think it's long-standing. I don't have the data in my office, but in some clinics around the country, I know of long-term, people that have been treated and still doing well. That's anecdotal at this point. We don't have long-term data. One of the things in hyperbaric oxygen therapy medicine is that our studies are expensive. We don't have a lot of people supporting it. So it's hard to get big studies. It's hard to get a lot of people involved. And it's hard to get this sort of longitudinal data that you typically see in these drug trials, right? In trials for new cardiac drug. Because we don't have, the profit motives. We don't have, we're all sort of mom and pop shops for the most part. Okay, so does that answer your question? Okay. All right. So TBI is the leading cause of morbidity and mortality in individuals under 45. in the world. And it's about a $60 billion per year cost in the US alone. Millions of ER visits, 52,000 deaths, 1.7 million brain injuries per year. It's astronomical. That's right, 1.7 million brain injuries a year in the US. Yes, question. The question is, what is the usage of hyperbaric oxygen therapy in other parts of the world? In Europe, it's ubiquitous. Denmark uses it for all their rehab patients. A lot of them, not everyone, but a lot of them. England, much more than here. Japan, China, they're using it for TBI. Israel, they're using it for TBI. All over the world, they're using it. So it's ubiquitous. It's a technology that's been around a long time, and it's very safe. And there's no real side effects, so to speak, that are not preventable. So throughout all these studies that I'm going to mention, nobody got worse. That's for sure, okay? And nobody had severe side effects. Nobody died, you know, nothing like that. So I think that's why it's so ubiquitous. People have been willing to try it in other parts of the world because the technology has been around for such a long time. It's not expensive in the macro sense, you know, if that makes sense. It's you know, so it's definitely being used around the world. Okay, so veteran traumatic brain injury. So it's also very common, and we think about maybe about 300,000 veterans at this point. I think that's a low number. Maybe double that. We don't know for sure. A lot of these guys have dual, triple, 4 diagnoses all at the same time: TBI, PTSD, substance abuse. You know, they've also had limbs taken off. It's depression. There's lots of things going on. That's I think why they're harder to treat in general. From a medical perspective, not even counting hyperbaric, because they don't seem to be harder to treat in the hyperbaric world. So mild TBI is, or mild to moderate TBI, is where 80 to 90% of all TBIs are mild or to moderate, okay, not severe. This is where most of the research is going because that's where most of the patients are, okay. I put up the definition here of what a mild to moderate traumatic brain injury is. What I wanted to sort of emphasize is that if it's lasts for greater than 3 months, it's now called post-convulsive syndrome. And 25% of patients have symptoms for 6 months or greater, okay? And after a year, if your symptoms don't get better, the likelihood that your symptoms are going to get better from there are very, very, very low, okay? And it seems to be in the military world that these guys have persistent symptoms for longer. And we think it's probably because of all the different hits that they're getting, all the TBIs, all the IED blasts, all the concussions that they sustain. So what's happening from a molecular point of view when a TBI happens? A lot of these are big words, okay? But what's really happening is tissue death. And the way that's happening is through a number of different, you know, sort of mechanisms in our body. Inflammation, swelling, cells will die from the swelling and lack of oxygen. Cells will program cell death, apoptosis, like I talked about before. The big picture, you know, TBI is either a focal insult, for instance, if it's a direct hit, or it's a global insult where it's sort of a diffuse hit, where you're hit from a number of different directions all at the same time. But on average, less than 10% of the brain is affected. Okay, and we're talking mostly here for mild to moderate TBI. Severe TBIs are usually global. So I wanted to kind of bring it down to a very simplified level here. Okay, I don't know if this projects very well, but what this really is supposed to represent is a still lake or a still puddle, whatever you want to say. You throw a rock into it, right? In the middle, you have a big splash, right? In that middle area, you have the area of injury, for instance, in a TBI, area where there's actually going to be tissue death. Okay? There's nothing you can do about that area. There's nothing you can do, whether it's a stroke or a TBI, okay? Because the cells are actually dead. But the ripples from the rock coming out from the rock where it hit dissipate as you go, right? Okay. So the ripples I define as what's called the peri-contusional area, or the peri-infarct area if it's a stroke. Okay. What that means is the area of injury, these cells are not dead. They're alive. They just may not be working at their maximal capacity. Okay. And we can see this on imaging scans. We can actually do imaging of the brain and see these areas of the brain around the area of injury that are just not functioning at maximal capacity by any means. What we think hyperbaric oxygen therapy is doing, and we're actually proving it now, is increasing blood flow, especially to this area, around the area of injury, okay? And that's regenerating those cells, okay? And that's what's causing the improvements that we're seeing. Regenerating the cells around the area of direct injury, okay? It's not just the direct hit that you worry about in a TBI or in any other brain injury or any other wound anywhere else. It's also the surrounding area that's damaged, okay? But in the brain, obviously, the surrounding area is very important. You know, we're talking about neurons here, right? So mechanisms of hyperbaric therapy have shown that we can increase neuron regeneration. We can increase neuroplasticity, the ability of neurons to change from one thing to another, okay? Mobilizing stem cells to this area. Most likely, we haven't been able to prove that in studies in people, but we're almost positive that that's happening. And those studies are going to happen, I hope. So why is it not easy to heal from a TBI? Okay, why is it so hard for our brain to do it? It's because our brain is working at maximal capacity at all times, okay? And even working at maximal capacity, we're only really supplying energy to 5 or 10% of neurons at any one time, okay? So it's very difficult for our brain to increase its energy supply enough to heal a wound, okay? It's very, very difficult. So these are just some numbers to just as reference. Cardiac output, the amount of blood that's being pumped out of the heart, 15% of that goes to the brain, okay? 20% of the oxygen in our body is consumed by the brain. Nothing else in our body except for our heart comes close to these amounts, okay? Utilizes 25% of the total body glucose, okay? The sugar that we need for energy. So we think, and it makes complete sense, that these cells need more oxygen, right? And now we're starting to see that more in studies that we're doing. And we'll go through that. So before I do, well, how is TBI treated now? And this is a great example of a place that's treating TBI. And I think it sounds like a phenomenal job, right? Here at, this brain injury center, what's the full name? Services for Brain Injury. And, this place is doing everything that it can to treat TBI patients, I think, from a rehab perspective: physical therapy, occupational therapy, vocational therapy, psychiatric counseling or psychologists to help, trying to get people back in the workforce, vocational therapy, giving them tools and resources and a place to congregate and to talk to other patients or other people that are also affected. So that's not the only thing that's happening, right? A lot of patients maybe in this room are taking medications to control symptoms, right? To control seizures, to control headaches, to control pain, to keep them awake or to put them to bed. These cycles can be all out of whack in somebody that has traumatic brain injury. So they're using all these meds, right? All these medications are patches, right? They're just patches on a problem. Do they solve do they serve a purpose? They probably do, because they help some patients function. Many of them have black box warnings on them that they can increase suicidality. It's a problem, especially in motivated people. Antidepressants especially. You have to be very careful. What these all are patches. And what we think hyperbaric oxygen can do, and what I've seen, is that not just be a patch. It can be an actual mechanism where you actually improve somebody's symptoms and get them off all these medications, or a lot of them in the process, as you can see from the veteran that I showed you in that video. So I'm going to go through some evidence, okay, and some studies that have been done recently. Some that have gotten a lot of press in my community, and even in the lay press too, all right? Some quote-unquote negative studies that were done by the Department of Defense that were recently published, as well as a couple of positive studies done for both acute, severe traumatic brain injury in the acute setting, as well as mild to moderate TBI in the chronic setting. Okay, that's where these trials usually run, either chronic TBI treated 3 months post-injury or acute TBI treated at the time of death. Okay. The other reason that I have negative in quotes is because they're actually positive studies, at least the first one. It's just how they define their data, and we'll talk a little bit about that. So, does anybody know what a placebo is? I have the definition of this, right? But no, it's something similar in the sense that what a placebo is a medically ineffective treatment. It's a sugar pill. For lack of a better comparison, if they take a sugar pill, you'll feel better in the morning. Okay, some patients will still feel better in the morning with a sugar pill, right? Because the mind definitely has a powerful way of improving our own well-being. If we believe something's going to happen, the placebo effect has shown us that we can improve symptoms just with the placebo. Actually, most effective placebos in studies are placebos that represent the treatment in every single way, except for the intervention in question, except for the one question that you have, right? Whether it be, does this medication increase your cholesterol or decrease your cholesterol? That's the question you have. Everything else has to be the same about the patient. Everything has to be the same about what other medications that they're on, all their demographics. That's what the idea is. You keep everything else the same, you change one thing, okay? The problem in a hyperbaric oxygen chamber, it's very difficult to do this, okay? And that's really where a lot of the controversy arises with hyperbaric therapy. In a chamber, I told you about that ear pressure feeling that you're going to feel. Right? So when you have that pressurization in your ears, you know you're getting hyperbaric therapy, right? So to simulate somebody getting into a chamber but not treating them is very hard to do, okay? That's where all these studies break down, the Department of Defense studies. And I'll talk about a little bit more about, you know, the details. I don't want to, there's a lot of physics and I don't think it's necessary. So let's talk about the first study, okay? This is probably one of the more recent studies that was published. A lot of words on the page. I try to make it simpler, but it was hard to do. But Roxwell and his wife, actually she's the lead author, he's the second. They published a study, they're a group out of Minnesota, and on acute severe traumatic brain injury, okay? They took 42 patients with severe TBIs. In the field, they were, you know, they had a GCS, a Glasgow Coma scale, average of 5, as low as 3, as high as 8, pretty much, okay? That's pretty severe traumatic brain injury. All these patients got the same care, okay, to start off with. They all got respirators, they all had burr holes placed in their brain to prevent pressure from building up. They were all sedated. One group got hyperbaric oxygen therapy, 1.5 ATA for 60 minutes, followed by 100% oxygen through one of those face masks that you may have seen in the hospital or in a movie. Basically just a face mask, just 100% oxygen, okay? They did it for 3 successive days, this treatment, okay? And they compared that group to the control or the standard kit. The only thing positive about this study group, I think, is that these guys, you didn't have to worry about placebo effects because they were sedated, they were intubated, they had no knowledge of what was going on, okay? There's no worry about them knowing that they were not getting hyperbaric therapy, the group that did not get it. Make sense? Yes? Okay. Okay. All right. So what were their results? They had a 26% reduction in mortality. Not only do they have a 26% reduction in mortality, they also had a 36% improvement in favorable outcome. Okay. The way they define that is something called a dichotomized GOS, which is a Glasgow outcome score. Okay. And that's defining people from a level 1 to level 5 about where they are functionally at 6 months. It was a significant result. It was the first time there had been a study back about 15, 20 years ago that had a very similar protocol, actually by these guys, by Roxwell, that showed that there was a significant mortality benefit, but there was no significant improvement in favorable outcome. This is the first study that has shown that there's actually been an improvement in favorable outcome as well. You could argue that improved mortality is also a favorable outcome, but if these patients are severely affected, it may not be, right? So that's controversial, of course. But suffice to say, people in this study had a 36% improvement in favorable outcome, which is pretty impressive. What it also showed is that the area around the area of injury, so they have holes in these patients' heads to prevent pressure buildup. A lot of people had skull parts removed for these kind of things. They found the area around the injury, that area sustained that oxygen that they gave them until the next treatment. So the oxygen that was given to them during the hyperbaric treatment, plus the face mask 100% oxygen treatment afterwards, was still there in greater proportions in the control group. So that oxygen concentration was still elevated. It also showed significant improvement markers of cerebral function, inflammation, and cell damage. Prevented cells, we think, from the markers at least, so we didn't see the cells under a microscope in the study, but prevented cells from having toxic damage. Okay, it decreased inflammation. It also decreased intracranial pressure. A big thing in these patients is the buildup of intracranial pressure. If you build up a pressure in the brain from water or for swelling, you have an injury. And it decreased that pressure until the next session, okay, the entire time. That was a significant result, okay? It stayed low. It stayed lower than the control for the entire time, but that's in that 24-hour window. Only 3 hyperbaric sessions. Only 3 done on 3 successive days. Yes, question? The pericontusional brain is the area around of injury. So as I mentioned before with the rock and the ripples in the pond, those are like the ripples, right? That's the pericontusional area. The area that's been injured but not completely dead, okay? The area that's still functioning but not functioning well because of poor oxygen, because of injury, and then because of poor oxygen sort of inflow into that area. Does that make sense? Right. It's much larger. The area, yeah, does that answer your question? Yeah, the pericontusional area is much larger than the area of injury by, by magnitude, and that's really why we think there's such an ability for hyperbaric oxygen therapy to potentially be successful, because all that tissue needs, we think, is oxygen, right? And you give it the oxygen, you decrease inflammation, you decrease pressure, you rev up the mitochondria in the cells so they produce their own energy, they start working better. It allows for things like neuroplasticity, those neurons and the cells around the neurons that sort of keep them up and support them to work better. Yes. Yeah. So the question is, in hyperbaric chambers, do people get claustrophobic? And the answer is not usually. If you are supremely claustrophobic, then maybe. But we have ways to deal with it. And if you remember from the beginning, the chambers are wide open, okay? You can see out from every direction. You can move in them, you can get up, you can sit down, can't stand in our chambers, and some chambers you can. But for the most part, as long as you don't have severe claustrophobia, it may take some medication to relax you to get through it, but we have very, very few patients that can't do it because of claustrophobia. It's definitely something we think about. Yeah. So I can't show you this video, so don't pull it up because it's copyrighted. But I wanted to put this right here in your slides so you guys have the link, and I also wanted to put it up on the web so you can see what can happen with a severe traumatic brain injured patient. Okay, 4 months down the line, getting treated with hyperbaric oxygen therapy, and the results can be dramatic. And this particular patient, Kurt, is one of the most dramatic patients that I've ever seen. Paul in New Orleans, who wouldn't let me show his video due to his own copyright, has had significant improvements in patients with TBI, especially severe TBI. This is one example, one very impressive example. Okay, so moving over, we take a break. Okay, so before I go over to a couple more studies, I think we're going to take a quick break, get some water, some refreshments, and we'll be back. Sure, well, we can put the previous slide back. I can do that. Sorry. I forgot that I was doing it. Okay, we'll be back. We're going to get started in just a second here. Hope you guys at home enjoyed your cocktail if you're drinking. Wait, it's only Wednesday, right? Okay, so thanks for hanging in. So we're going to kind of focus now on mild to moderate traumatic brain injury, which is where most of the research is going right now. This is a study that was published out of Israel, and Israel actually is doing some pretty impressive stuff in all types of medical, in all medical fields actually. But hyperbarics is not an exception. They have a very large chamber. They treat about 120 patients a day, a lot of them on study protocols in Israel actually. This is a study that was just published, post-concussive syndrome, years after mild TBI, okay? So most of these patients are between 1 and 6 years after their injury, okay? 56 patients. They treated with 40 sessions of hyperbaric oxygen therapy, which is the standard therapy that I mentioned, 1.5 atmospheres of pressure over 2 months. So I didn't make this clear, I don't think, in the beginning, but hyperbaric oxygen therapy, when you're getting it, is Monday through Friday, every day with the weekends off for those 2 months, okay? An hour each day. That's what they use in this protocol. That's what we use in my office, okay? And clinics all around the country are using the same protocol. They not only tested these patients using cognitive or sort of, brain, brain tests, see how your brain was functioning. But they also use what are called SPECT scans, S-P-E-C-T. The SPECT scan is actually a functional image of our brain. It's an image that shows glucose uptake. And as I mentioned, the brain is a very big glucose user, right? You can use these scans to show where glucose is being, where the uptake in the brain is happening, okay? They use these scans before they went into the chamber and after to see the differences, okay? So what did hyperbaric oxygen therapy do to these patients? It significantly improved their processing speed, their ability to do things quicker. They improved their attention, their memory, their executive function, again, planning, working memory, and their quality of life, okay? The most important part of this study, I think, well, there's 2 parts, but probably the most important part is they found on these SPECT scans, which I'll show you in a minute, there's significant improvements in blood flow correlated to the areas of improvement on cognitive testing. They saw where these patients improved, and they correlated to the areas on the SPECT scan where there's increased blood flow, named that. Okay, that's telling you right there. And not only are we seeing improvements in blood flow on a brain study, we're actually seeing it in real life. We're seeing it in patients as well. Okay. Yes, question. The SPECT scan? Oh. So the question right now is, what types of doctors are recommending hyperbaric oxygen therapy? The answer is most doctors that are recommending it for what we call on-label conditions, or conditions that are covered by the insurance company. Diabetic foot wounds, radiation injuries, burns, infections, things like that. Those that are suggesting it for hyperbaric oxygen therapy are usually in the rehab world, usually in physical medicine and rehabilitation, neurologists. There are more and more neurologists that are becoming more aware of what we're doing. One of my jobs, one of the reasons I'm here, is to make sure that more people know about what we're doing, doctors included. I go to physicians' offices all the time, trying to give them this research, showing them that what we're doing is helping patients. Okay, but it's an uphill battle. For any new thing in the medical world, it's an uphill battle. Doctors are the last people to sign on most of the time. Yeah. The question is why? That's a very complicated question. I think the short answer is because. That's all. There's no reason, but it's just because everybody has their own biases. Everybody has their own ideas of what works for their patients and what doesn't. And what most doctors want to see is called randomized control trials. Those are very hard to do in the hyperbaric world. I'm going to talk about 2 of them that have been recently built up. Okay. You have another question? Well, maybe. Okay, so I wanted to show you the scan. So this is from the Israeli study. Okay. Question? I'm sorry? So PET scans? Yeah, so the question is, are SPECT scans supported by PET activity scans, or are they correlated? But we don't do PET scans because they're too expensive, okay? But it's funny that you should mention that, because I think recently in the news in the last week, there was a study recently done showing that PET scans can be a marker for how severe somebody's traumatic brain injury is, okay? And not shocking to me, it's a glucose uptake study. Very similar, except much better quality than a SPECT scan. A SPECT scan is less expensive. Been around longer. That's the reason why they're less expensive. Yeah, because PET is too expensive. They haven't done research with PET scans yet. Yeah. So SPECT scans are very specialized radiological tests. They're not done at my office. They're only done at specific places that you're doing research on SPECT scans for studies like this. Or there's a place called the Amen Clinic. They're all around the country. They have SPECT scanning as one of the things they do to work out patients with brain injury. Not only TBI, but ADHD, ADD, autism, the whole, concussions, strokes. They do it all. They have SPECT scans at those locations. They're all around the country. Amen clinics are all around the country. That was the question. I'm sorry? There's one in Brisbane, up near San Francisco. So the price of SPECT scans is expensive because it's not going to be covered by insurance. So that's the whole issue. This sort of, I guess, the elephant in the room is a big elephant. Is that none of this is covered by insurance? Okay, because it hasn't reached the point where the FDA has decided, or the insurance company has decided they're going to be covering this for patients. Okay. So all this is out of pocket, and that's a huge challenge. And one of the reasons actually why doctors don't recommend it as much as they might, because they know it's going to be an out-of-pocket cost for patients. Yeah. SPECT scans are not typically covered by insurance, except for very specific indications. I'm a practicing physician. I don't ever see SPECT scans. I do see PET scans. I do see those a decent amount, but SPECT scans are not that great of quality compared to PET scans. They've been around a longer time. So let me go through this PET scan real quick. This SPECT scan, excuse me. So what they did is they looked at patients' brains before they went into hyperbaric oxygen therapy. Okay. This here is kind of a scale as to the amount of blood flow in an area. I know it's kind of hard to project, it's hard to see, but black is the worst flow, white is the most. Okay. And then you can see in this patient's brain, it was a 51-year-old lady with a motor vehicle accident, mild to moderate TBI. She mostly has red everywhere. But if you see there's all these yellow pockets, and you really can't see it that well, but there's a green pocket right there. And I bet you anything, this is where her main point of impact was, okay? You see some underneath side of the brain here. You can see some of the areas also a little bit of green. Can't see project all that well in the yellow. Again, not as well functioning as the red area, okay? After 40 treatments, not only do you see most of that yellow is gone, especially, there's no more green left, okay? But all you see all around here, all this white that wasn't there before, right? All that white is extremely metabolic tissue, okay? In the area of the frontal lobes where this is, in the area of the temporal lobes where this is, on the side of your brain, that's where we store most of our memory. Storing is the wrong word. That's where we process most of our memory. That's where we process most of the data that come to us all day. Visual, spatial, and learning. Executive function, all in these areas. So there's a significant improvement here, okay? Okay, this is another study that was done by that guy, Paul Arch, that I mentioned, physician down in New Orleans. He treated patients with blast injury from Iraq and Afghanistan, 15 patients, 40 treatments, 1.5 ATA, over 2 months. Actually, no, he did this over 30 days. So he did 2 treatments a day to get these patients through the study as quickly as possible. He also did SPECT scanning. He also did these functional imaging scans on patients to document not only that these patients were improving on testing that they did, but also on imaging, okay? There was no control group in this study, okay? It was just patients getting treated. So what did he show? He showed that there was a significant improvement, symptomatic, cognitive, affective symptoms. Affective is mood symptoms, okay? 30% reduction in PTSD symptoms. It was actually surprising to Paul and the guys down there, because they weren't treating for PTSD, they were treating for traumatic brain injury. But what he found, and what we're finding in the literature, and more with hyperbaric oxygen, is that it's a continuum, right? TBI, PTSD, especially in these vets coming back, is a continuum. That guy, the veteran that I showed you in the video, they said that he had PTSD, but he didn't just have PTSD. He had PTSD, TBI. It's a continuum, okay? These patients improved significantly with TBI as well as PTSD, an increase in 15 points on their IQ, okay? What I found most impressive, because I'm an internal medicine physician, I see patients on tons of drugs, and I see TBI patients on tons as well. 64% of patients were able to decrease or eliminate narcotic and psychoactive prescriptions. That's significant, okay? These guys were getting their life back, you know? And he showed on SPECT scanning these improvements. You can't really see this too well, but what I wanted to show was a particular area of the brain called the hippocampus, okay? Which is these little red spots over here, okay? The hippocampus is this area in the brain that's very sensitive to traumatic brain injury, okay? It's also very plastic. What I mean by that is it also regenerates itself very well. What its main function is to improve the ability for us to make short-term memory turn into long-term memory. That's where it happens in the hippocampus, okay? What Paul was able to show was that you have increased blood flow to the hippocampal area with hyperbaric oxygen therapy. And it was a significant result. And this is just sort of a corollary to what he saw in tests. These patients were doing better, and he was able to show on their brains this is why, because that increased blood flow to this particular area of the brain. Okay, so now to get to the controversy a little bit. Does anybody have any questions? Yes. Right. So I guess not so much of a question, but the statement was, you know, by increasing oxygen to certain areas of the brain functions better. And I couldn't have said it better myself. That's really what it comes down to. You know, all the mechanisms of action, everything that's going on, the brain functions better, and we see that on scans. The great thing is that we're doing these scans to actually show, and we're saying, look, we can put it up in light. It's, you know, it's radiology, it's images. You can see it. That's what's happening. Okay, that's a great point. So there have been two recent Department of Defense studies that have been published. One by this guy Wolf, and then another guy named Sifu. I don't know how to say his name. I think that's how you say it. They both worked together on these two studies. So I wouldn't call them independent studies at all, but they were both funded by the VA to look at mild to moderate traumatic brain injury in veterans coming back from the wars in Iraq and Afghanistan. They treated patients at two different levels of hyperbaric oxygen therapy. Their placebo group was a group that got a little bit of pressure and not 100% oxygen. And there was another group, their treatment group, that got a lot of pressure, 2.4 ATA, which is much more than we typically treat, by the way, for hyperbaric oxygen therapy and TBI, at 100% oxygen, okay? I don't want you guys to get lost in the details. The big picture here is that they treated two groups of veterans at two different pressures, one with 100% oxygen and one with just air, compressed, okay? And they looked at these two groups as a treatment group, the one that was getting 100% oxygen at deeper pressure, and as a placebo group. They called it a sham group, okay? Because even they knew it wasn't really a placebo, okay? So, and I'll talk more about that in my next slide. They did two different types of testing on these guys. Impact testing. Again, impact testing is the test for traumatic brain injury. So it's a computerized test you take on the computer. PCL-M testing is testing for PTSD. It's also a computerized test. Very quick, easy to do. They tested before and they tested 6 weeks after therapy. So I'm going to go back to that. sorry, so back to the slide for a second. So their conclusion was there was no effect of hyperbaric oxygen therapy. That was their conclusion, because they thought they compared the placebo group, the sham group, to the treatment group, and there were no differences between the two. But what they didn't talk about was the differences within each of those groups. Okay, so comparing the sham group before and after, and the treatment group before and after. Because if you look at them together by themselves, just the treatment group or just the sham group before and after, there were significant improvements in these patients. Okay, and this doesn't project very well, but what I wanted to just kind of show you is that their data shows the improvement. They just didn't talk about it this way. Okay, and the reason why they attributed this all to placebo effect. Okay, of the hyperbaric oxygen therapy itself. Okay, but what happened here in the sham group, in the group that wasn't even getting 100% oxygen, okay, they were getting 1.2 atmospheres of pressure, which is about 13 feet of seawater with compressed air. These patients improved in 10 of the categories that were tested for impact testing. Okay, significant. Okay, meaning that their p-value, this value that we test when we're looking at studies, was significant. Okay, so, and then if you look at the 2.4 atmospheres, the treatment group in this study, 2 of those tests were significant. So not as significant, but so they're actually showing me something very, very, very important here. They're showing me that if you treat somebody with hyperbaric oxygen therapy, compressed air, not even 100% oxygen, and put them in a chamber, 1.2 atmospheres of pressure, you get significant improvements in these patients. That's pretty impressive. But that's not what they talked about. They talked about that there was no difference between this group, the sham group, and the treatment group, if you looked at them compared to each other, but not compared to themselves. That's the difference. I know that's complicated, but suffice to say, their data shows that they actually had a very successful trial in treating patients. And even at the end, they even talked about, well, we don't understand why this happened. Why did everybody get better? You know, people aren't supposed to get this much better after having a TBI after a year. As I said to you, it's very rare to have improvement after a year. Okay, they even showed it on PTSD symptoms as well. Again, these are veterans being treated. So the composite PCL-M score was significantly improved in both groups. Right, both groups got better. Okay, again, they attributed all of this to placebo effect. They attributed everything that happened to these veterans by being in a chamber, being off duty, because these were military guys. So they were stationed in a nice place in North Carolina where they got to be on the beach. So they think their conclusion was that all of these effects were just purely from placebo effect. Okay, but even they'll admit that their sham group or their placebo group was not a placebo. They were getting 1.2 to 1.3 atmospheres of pressure. Okay, if you do that, you're increasing oxygen saturation in your blood 50%. Okay, that's not a. I mean, is that a placebo? Is that medically ineffective? The answer is absolutely no. Okay, the 2.4 group that was their treatment group was much too much pressure from our observational data about what the best pressures are for hyperbaric oxygen therapy for TBI as well. And in fact, they even saw that in their study. Some patients actually got a little bit worse in the 2.4 group, and then they got better, or went back to about being the same as they were before. There was no functional imaging, no SPECT scanning, no PET scans, nothing to prove or to disprove their theories. Okay, and they only treated these patients for 30 treatments. As I said, the typical protocol is usually 40, if not more. Okay, does everybody kind of understand? The big picture is that they made a conclusion saying that there was no effect, but in fact there was a significant effect, especially in the group that was treated at a lower pressure, the pressure that's very similar to the one that we treat in our chamber, and in fact it's much cheaper, interestingly, to treat somebody at 1.3 atmospheres of pressure, right, with compressed air instead of hyperbaric air, 100% oxygen. So where the study should go from here is testing 1.5 with 100% oxygen to 1.3 at compressed air, right? And actually that's going to happen, hopefully. So this is the other study that was recently published, and that some people in our audience got presented to them at the World Congress of Brain Injury in San Francisco. This guy, Sifu, he is a researcher. He's also in the Department of Defense. He's a military guy. Their study was in combination with 4 studies total that are being done by the VA in research for traumatic brain injury. Okay, there's been a big push, a big sort of groundswell from people like people in this room, people in the TBI world wanting these studies to be done. In fact, in Oklahoma, there's even legislation trying to get study protocols extended to patients just to get them treated. Okay, so anyway, so this study is ridiculously complicated for what they're trying to simulate. Okay, but suffice to say, there were 3 groups. All 3 groups got pressure. Okay, all 3 groups got oxygen, and they compared all 3 groups together, and none of the 3 groups had any differences between them. Again, same thing. Okay, they had 3-month data that they just reported on some other sort of testing. This is RPQ. It's another test for TBI, so similar to the impact testing. They just published some 3-month data, showed the same thing. Okay, what they didn't mention is that in all groups, PTSD symptoms improved. Okay, they didn't really talk about that in their abstract or in their main body of it, but they did report it in the body of their paper. Again, they attributed this to placebo effect. Okay, being in a hyperbaric chamber. And then at the 2 ATA group, that level, they actually had significant improvements in TBI symptoms. Okay, but something's happening in these patients. Okay, and even in the end, they did say for all patients in the study, there was an improvement in working memory, executive function, delayed verbal memory, and verbal fluency. So something happened to these patients, right? You know, they got better. Even though the protocol is complicated, and they use nitrogen as a very big part of their pressurization technique, and the questions about that are endless, actually, and for another time. But suffice to say, everybody got better again. So what happened, right? Something's happening to these patients, and I see this all the time in the patients that we treat. Patients get better. So these are the system studies that are occurring right now. Somebody asked me about what's happening, if they can become part of a study protocol. Unfortunately, there's not enough out there for study protocol. The MBR trial is a trial that's been ongoing for several years. It's an observational study, meaning it's not placebo-controlled study. But they've treated about 30 or 40 patients so far, very successful in the protocol that I've mentioned, 1.5 ATA for 60 minutes for 40 up to 80 treatments in these patients. A significant improvement. There's a civilian trial right now that's recruiting in Utah. And so they're actually going to be testing patients at that compressed air level that I mentioned versus 1.5 ATA at 100% oxygen. So I can already tell you what the study is going to show you. They're going to tell you there's no effect of hyperbaric oxygen therapy. Okay, that's what they're going to tell you. But my guess is, if you look at it closely when it's done, is that there's going to be significant effects for everybody. Okay, and then if you look at the groups compared to themselves before and after, everybody's going to improve, and it's going to be significant. Okay, the question is going to be, what's the difference? How much more significant was it in the 1.2 versus the 1.5 group? That's what I want to know, because I know what the conclusion is already going to be, is that nobody got better. It's all placebo control. It's all placebo effect. There's a military trial, last military trial that's happening. That's going to happen. It's actually, I think it's going to publish at the end of the year. And again, I think they're going to have the same conclusion. But if you pierce out the data, I think it's going to show the same things that I've showed you already. Now, acute concussion management. We haven't talked about that. This is a big thing in the NFL, right? There's a lot of people in the NFL that are hyperbaric oxygen has been talked about. Let's say it that way. But the problem with that is that, you know, it's a very labor-intensive and a very public thing for the NFL. There's some ideas about trying to treat patients on a lower level if they have acute concussions. As I sort of mentioned, we think the shorter time it is between getting in a chamber and having the injury, the less therapy that you need. Right? Shorter time to get in, the less therapy you need. So the idea is, why don't we treat these patients as soon as they get the concussion? Treat them for 2 or 3 treatments and see if they can get on the field quicker, see if their testing gets better quicker. It all makes sense, you know, but it's all about money. That's where we talk about show me the money. It's all about money and studies. Where the NFL is really focusing more of their money, actually 50 million, I think, is to brain research on diagnosing CTE, or chronic traumatic encephalopathy. Not on the treatment as much as the diagnosis, which I think is flawed, but that's what they're doing. The NFL right now is sort of a, for a long time they deny that there's any injuries related to NFL, from concussions, etc. But they've, there was a recent lawsuit, as some of you may know, that had supposedly been settled, but now I don't think it's actually been settled at all, trying to give patients compensation for these injuries that they didn't know about before they went and became players. That's a work in progress, that's for sure. So what is the protocol? I've mentioned this as we were going through, but I just wanted to kind of codify it for you as best I can. 40 treatments, up to 80, sometimes more, as I said, but definitely 40 treatments for the most part. If the traumatic brain injury has been going on for 3 months or longer, it's 40 treatments. Before 3 months, it's still questionable. We don't know. Monday through Friday, 1 hour at a time, with the weekends off. We give you the weekends off, right? That's nice of them. And for 2 months, okay? 1.5 ATA, which is the 1.5 atmospheres of pressure, which is about 15 feet of seawater. It was what the equivalent is for 16 minutes. At my office, not at all offices, but they should really be doing this, I think, and more are, is neurocognitive testing. Because the problem with a lot of testing for TBI is that a lot of it is self-directed, okay? So how are you feeling today, okay? The problem with that therapy is that typically TBI patients are the last people to know that they're better. In fact, the last people. So you need objective data, we think. So that's why we give them this objective data. We test them at 0 treatments, we test them at 20, we test them at 40. And the way we treat at my office is we try to treat to plateau until symptoms are no longer getting any better. Okay. Even that being said, that's why we take a break at 40, because patients can have significant improvements after the 40 treatments. 2 or 4 weeks later, we don't see the full effects of what we can do until that time. Okay. So then we decide whether do we need more therapy, how are we doing, and then we decide whether we need more. Okay. So concurrent rehabilitation, that's really a big question. They've taken that out of all of these studies. Okay. All the studies that I showed to you, none of these patients are getting rehab. Okay. Well, you ask, well, why would that be, right? It's because they're worried that if somebody gets better, can they attribute it to hyperbaric oxygen, or is it because of the rehab that they were doing? Okay. So it becomes a confounding variable. Okay. That's what it means. So that's why they've taken it out of all these studies. But it just makes sense, right? As far as I'm concerned. And a lot of people in my position are concerned. You do rehab, you rework your brain. We know this happens with rehab, right? And then what if you're giving your body the energy it needs, the oxygen it needs to supply those cells with the function that they can have? What I tell all my patients is that the more therapy they can do, the better, okay? The more concurrent therapy, the more therapy before, the more therapy after, during, the more that they can tolerate, as much as they can tolerate to a degree, okay? We don't want somebody being so tired that they can't function. But get as much done as you can and do as much as you can to rework your brain at the same time. That's where I've seen the most success in my office. So side effects. It's an important question, right? What are the side effects of hyperbaric therapy? I want to start with saying that hyperbaric oxygen therapy is very, very safe. It's been around a long time. The first compressed air invention was actually in the 1600s. Okay, so hyperbaric oxygen therapy sort of grew out of that over many, many years. Bridge building is still used. In fact, those chambers are still being made for bridge and tunnels, saturation chambers, so patients don't get the bends. Okay, the most common thing that we see happen is ear barotrauma, or problems with the eardrum. Okay, if you can't pop your ears when you're going down in pressure, if you can't pressurize, then air is going to build up on the inside and the outside of the ear canal. And if you can't get that pressure to dissipate by popping your ears, by using maneuvers like you would on a plane, opening up your mouth, moving your head side to side, then you can burst your eardrum. Okay, it's very, very rare though, because the good thing about these chambers, even though you're sealed in the chamber, is that we can communicate with you the entire time. Okay, you just talk, we can hear you. We talk to you by walkie-talkie. So you have to tell us that you have pain. If you have pain, if you have stuffiness in your ears, you can't clear it, you tell us. We can stop the pressurization at any time, and we can get you to pressurize your ears. Okay. Now there are some cases where we're not successful, where we can't get patients to pressurize. The two most common scenarios here are patients with severe TBIs that can't follow directions, or in patients that simply can't do it. And that happens very rarely, but it does. In those two populations, what we do is we can put tubes in patients' ears. Like if you've ever heard of kids getting tubes and they have chronic ear infection, okay? You can get a temporary tube placed in your ear by an ear, nose, and throat doctor. When you get a tube into that tympanic membrane, into that eardrum, it pressurizes your ears automatically. You don't have to do anything. You don't have to open up your mouth. You don't have to do any pressurizing at all, okay? It solves the problem. So I could tell you maybe 1 out of every 50 patients that we treat in my office will need something like that. That's probably a high end. 1 out of 100, I would say, 1%. For everybody else, we can usually work with techniques to get patients through this. Okay, so vision changes. Temporarily, your vision may change. It may make your far vision worse. Okay, so that gets better. 1 to 6 months after therapy, your symptoms are usually fully better. If you have cataracts before you start therapy, it may make your cataracts mature quicker. Okay, so your cataracts may build up and get bigger quicker. Okay, it won't make cataracts happen, but if they're there, you may potentially need surgery quicker to get them removed. It increases insulin sensitivity. So in diabetics, we have to be careful and make sure that they eat before they go in. If somebody's prone to low blood sugar, they should eat before they go into chambers because it can decrease your blood sugar. Now, claustrophobia we already talked about. It's completely doable to go into a chamber with claustrophobia. Sometimes it takes some anti-anxiety medication. We have a lot of success. So rare side effects, again, these are very rare. Oxygen seizures, it's basically related to toxicity of oxygen, okay? This oxygen seizures only happen in patients that get a lot of therapy. Seizures that do happen are self-limited. They don't last very long. We can get them to stop. They do happen, and there's no residual effects afterwards, okay? Patients that are high risk, we sometimes put on anti-seizure medications empirically. There's also mechanisms of how we treat patients in the chambers, something called air breaks in the chambers themselves to make the risk even lower. For TBI treatment, very uncommon at the level of pressure we're using. Typically happens at much lower pressure. Pulmonary toxicity, this only happens in patients that have underlying lung disorders, okay? COPD, emphysema, that's really what I'm talking about. Pneumothorax is where your lung actually deflates and drops. This happens very, very rarely. It only happens in patients that have an underlying lung disorder as well. Patients that have been smokers, we have to make sure we get chest x-rays before they go into the chambers. Patients with COPD, same thing. Fire. Okay, so if you're in an environment in a chamber that's high in oxygen, okay? Oxygen is flammable, okay? So we take this very seriously. There's only been 3 fires ever in the hyperbaric oxygen therapy, hyperbaric oxygen chamber, okay? But we do everything we can, and you should make sure if you go to a chamber, they're doing everything that they can to prevent this, okay? What that means is 100% cotton scrubs that our facility provides, okay? Nothing that could be flammable, no oils on your skin, no deodorants, no jewelry, no makeup, no undergarments, just scrubs, 100% cotton scrubs that we launder ourselves because we know what detergents are being used, okay? We even have a little metal wand that we can wave against people to make sure they don't have any metal on them. We just got that. But we do everything we can to make it as minimal as a risk as possible. As I said, it's very, very rare. Under the right supervision, which is very important, by the way, with hyperbaric oxygen chamber, okay? So if you're looking for hyperbaric oxygen chamber, there's a couple of things you want to look for, okay? You want to look for a physician that's running the place, okay? It's really important, I think. Maybe I'm biased, I'm a physician too, but you want to have certified hyperbaric technicians, certified people that know how to work chamber, okay? And you want to have medical supervision most of the time, okay? For most indications for hyperbaric therapy, okay? You want to have a PA involved, you want to have the doctor involved in care, you want to see the doctor, you want to have follow-ups with the doctor. I don't recommend going to a place that you never see a doctor, okay? And there are a lot of places around the country, unfortunately, that are like that, okay? I just worry about safety, okay? And I worry about protocols, and I think that's probably the safest way to go, okay? So fire, very uncommon, but it's something we have to think about. These are some more relative contraindications or relative, potential problems with hyperbaric therapy, or potential problems that could make hyperbaric therapy risky, okay? But all these are relative. The only one that's an absolute contraindication, you can't get into a chamber, is if you have already a drop lung. You can't go in, okay? They won't let you in. But otherwise, for the most part, everything else is almost is possible, okay? I'm not going to go through the entire list, but the big things to mention are some chemotherapeutic drugs, asthma. As long as it's stable, as long as it's controlled, you can go into a chamber. Seizures, if you have an underlying seizure disorder, you can still go into a hyperbaric oxygen chamber. We'd have to make sure that your seizures are controlled. It will not make your seizures worse, okay? Upper respiratory infections, we all get these, and the reason why it's on this list is that when you get congested in your face, it can make it hard to clear your ears, right? There's ways to prevent or to make therapy much more, tolerable beforehand, as long as we know that somebody has some congestion. Okay, one more. Okay, cost. We've talked about this a little bit. It's not covered by insurance, okay? In the Bay Area, each treatment is going to cost between $200 and $290 per session, okay? Hyperbaric oxygen therapy is not cheap, okay? For all the things that I mentioned, the chambers themselves, the oxygen, the supervision. This is cheap, actually, compared to hospitals, okay? If you go to a hospital, they'll charge you $1,500, okay? At the least, okay? Some facilities do offer discounts, if they can. We are one of those people that try our best to offer discounts when we can. But only freestanding, only places like myself that are not affiliated with hospitals will be able to treat TBI patients. Hospitals do not usually treat TBI patients unless it's on a study protocol. They're only really allowed to treat the FDA approved indications for hyperbaric. Question? Really good question. So the question is rental. Rentals, what they're talking about there are hyperbaric oxygen therapy chambers, okay? They're not even hyperbaric oxygen chambers, really. They're soft bag chambers, they're compressed air, okay? There have been no studies with these things at all, okay? Unfortunately, they're touted as being the same as hyperbaric oxygen treatment, that I've shown you, the acrylic chambers, but they're not, okay? Now, that's not to say there may not be a role for them, okay? And there may be. We don't know yet. There's been no studies at all on these, except for acute mountain sickness. If you go up on a high elevation, put yourself in one of those chambers, it seems to help. That's it, okay? So I don't recommend them for a couple of reasons. Number one, what some people are doing, which is very unsafe, is trying to pump 100% oxygen into these soft bag chambers. You don't want to do that, ever, okay? Because it's a huge fire risk in somebody's house, all right? The second thing is that they're not being monitored, okay? And then we don't think they're really as effective as the 1.5 atmospheres of pressure that I mentioned. But as I said, there may be a role for them. 1.2 is what they typically can get to. I guess it's an unanswered question so far. But overall, I can say that there hasn't been any data at all, no research on these chambers at all. And anybody saying there has been is not telling the truth yet. Yes, there may be at some point. Okay, all right. Locations, I mentioned this briefly. I'm in San Francisco. Very easy to get to, though. We're right off the freeway. There's regional center in medical in San Jose, not Santa Clara Valley. They don't have hyperbaric chambers. St. Francis Hospital in the city. Bay Area Hyperbaric. They have 2 locations on the peninsula. They have one in Los Gatos, and they have one in Los Altos. Janine, I think it's Janine. I can't remember her name that runs it. But they have hyperbaric chambers like ours. They're a little bit different. You have to use 100% oxygen mask. to get the oxygen, and the chambers aren't as they have some chambers like ours, but I think most of their chambers are like little portholes, which I can show you pictures of if you're interested. But they do the same thing in the end. And then I work with a company in New York. That's where I'm from, as I told you in the beginning, called Hyperbaric Medical Solutions, and they have 2 freestanding facilities. They do the exact same things that I do in San Francisco. So the question that Carol raises is, are VA hospitals giving hyperbaric oxygen therapy to vets? Is your question for TBI? Okay. Okay, so there are a lot of hyperbaric chambers in VA actually, but they're only being used on study protocols for TBI and PTSD. That's it. Okay, they're otherwise being used for the FDA approved indications. That's it. Right. Because it's not FDA approved at this point, they're not using it for those indications. Right. Although I hope in the next 3 to 5 years we see a huge shift. I really do. And I think we're going to, because the groundswell is really there, you know. And there's one trial that I mentioned briefly before I go, called the MBIR trial. They're doing in Oklahoma, there's a lot of legislation trying to get this study protocol approved by the legislature to be used for vets in Oklahoma, because the results have already preliminarily been so great. Okay, I really hope that happens. Anyway, conclusion: hyperbaric oxygen therapy is very, very safe. Okay, as I mentioned, nobody gets worse in these studies. Okay, and as I said to you, almost everybody seems to get better. Okay, hyperbaric oxygen therapy heals wounds. As this gentleman said, it brings oxygen to places that are not getting enough and heals those areas. We see patients improve every day. We really do. And it's an open question about additional rehab with hyperbaric. But I think if you can do it, I think it's, I mean, as far as I'm concerned, this could be a huge, huge improvement in patients if they use rehab at the same time. Physical therapy, occupational therapy, speech, vocational, everything. As much can be done, should be done. The problem, as always, is the elephant in the room, is the cost. Any questions? Yes, that's right. Yeah, the comment is you know, green plants do produce oxygen, and maybe we should be around more green plants. And there's, I mean, in the big picture, you're completely right. You know, as far as greenhouse emissions, and our warming climate and everything like that, and just I agree with you. You know, oxygen is a good thing. I agree. And carbon dioxide as a byproduct of not having those things is you know, is ruining our planet. So yeah. Any other questions? Yeah. Sure. Okay, so I'll start with the first question. The first question is, why isn't everybody getting treatment? And yeah, it comes down to money, you know, and it comes down to the medical world not believing that it works yet. Okay, because as far as they're concerned, these randomized clinical trials, controlled trials, were not effective. Okay, the groundswell is there. I think if the state of Oklahoma can get this bill passed, which they have through one of their houses, and they treat people on a massive scale, then it's going to be a domino effect, you know, where more and more states are going to pass the same kind of legislation, because they're going to have to when they're seeing what these patients are able to do. And and some of the recoveries that they're having. The corollary to that question was how long? How long is there a time where it's no longer effective? And the answer is that we don't know. We think that even in our experience treating patients even 25 years later, I could tell you about a vet that I saw in my office 25 years ago, Vietnam, severe PTSD, every night had nightmares. After 20 treatments, he stopped having those, and they never came back. They haven't come back yet, and it's been 2 years. Okay, so we don't know the answers. I think it's always worth a shot under most circumstances. The answer is last question. The last question was mine workers, right? They're all under compressed air underground, so they are getting some of those effects. And in fact, a lot of the way hyperbaric oxygen therapy became a medical treatment was they saw all these patients getting hyperbaric therapy for the bends or for decompression illness, and they saw like, wow, they're getting better with X, Y, and Z. Their wounds heal faster. Their radiation injury is better all of a sudden. So you're right in some ways. These patients can potentially improve and have some of these same effects. Divers do. Divers will tell you that they feel better after they come up from a dive. And it's a lot of that is getting the extra oxygen that they're breathing in. What was your question? Yes, the question is, can you get a copy of my electronic slides? And the answer is absolutely. I don't have any copyrights. I'm happy to disperse. As many people as you want to read them, please. Okay. I brought some of my cards, and I brought some brochures from my office. You're welcome to email me, call my office. If you don't live in this area and you want resources, you can call. You can go on our website. You can ask questions. We can direct you to where might be a place for you to go. Yeah. That's your what? I'm sorry? You're in the toilet. In the toilet? Yeah. Well, because there's no treatment. There's really no effective treatment for patients. So the question was, why did they decide after a year that these patients were no longer able to improve? And I think it's because, number one, they just haven't seen it. Patients don't seem to improve, and there's no effective treatments to help them improve after that year. You can give them drugs, you can give them therapy, but nothing seems to help the underlying issues anymore. So that's where hyperbaric oxygen therapy is really coming into play. That's where these studies actually were done, most of them 3 months post-injury, even the Israeli study in a year, just to make sure these patients were not going to get better. They were not going to improve with anything else other than hyperbaric therapy. Yes.
And in fact, there have been a number of studies that we've done and that others have done, but there is progress actually, not just 1 year, but greater than 2. Not everybody can fit.
Right.
But you see people who are coming back to a little bit better than this, a little bit better than that.
Right.
So it's not necessarily that out of a year, 90% can get it back. It's not because it's the end.
Okay, it's a really good comment. And our comment is that some people do improve after a year. And the answer is yes, but the majority don't. About 90% probably don't improve dramatically. Okay. But there's absolutely room for improvement in a lot of these patients. And you're seeing that, and I know you will. And that's a good point. Yeah. Sorry. The question is, what's the difference between a regular oxygen tank, I think by a face mask is what you mean if you're going to breathe? Okay. Versus the chambers. And I know I've said a lot in this talk. One of the first things that I mentioned was when you're breathing air through a face mask, through like an oxygen mask, you're not getting you're not getting any pressure with those breathing. Hyperbaric oxygen therapy is not only oxygen, but it's pressure. But the pressure is key. Okay, the pressure is key to get that oxygen into your bloodstream, to get to the place that it needs to go. Without that pressure, I can give you 1,000 liters of oxygen by mask, but it's only going to do so much to your bloodstream. You have a question over here? The studies were done on patients that were far out. On the mild to moderate TBIs, at least 3 months. Average was over a year. No, most of these patients were between 3 months to about 6 years. Right. So the question is, do we have any idea 20 years later if we're going to be helpful? The answer is only anecdotally, only from patients that we do treat in our office, and no studies to show that. Yeah. No. One more question?
DOD is almost one of the most people giving you resistance in developing it.
The Department of Defense, the question is the DOD, are they resisting hyperbaric oxygen therapy? That's a debatable question.
I mean, they're very big in doing research studies and stuff. I'm seeing just like this, right?
Stanford, yeah, so the question is Stanford doing anything like this? Stanford doesn't have any hyperbaric oxygen chambers. The VA down in Palo Alto does not have any either. They have them, I think, somewhere not too far, maybe an hour away. Something that would be completely doable, actually. And I love it. I love to see it happen. You know, I've tried to talk to patients, to physicians at Stanford, at UCSF, but I haven't had a whole lot of success thus far. There's a lot of reasons for that. Right. You do use it for diabetic patients. The VA is very strict about what they do. Yeah. You know. Right. Right. Yeah. Yeah. Well, I just want to say thank you very much for you all coming. I hope this is I hope it was informative. I know it's a lot of information, but you have slides, and if you'd like to, I can send them over to Kim. Thank you, Kim, again for organizing this. Thank you, Kim. Thank you, Carol. And we can get you those slides if you like them. Okay.
And we'll pass them out, and you've already